A tool that is used to build the IFSP is the Child and Family Assessment. And this relates to key principle number 1 that we just talked about a moment ago. Infants and toddlers learn best through everyday experiences and interactions with familiar people in familiar contexts. That Child and Family Assessment tool is used to build the IFSP and is necessary for identifying strengths, needs, and priorities within the current routines and activities of the family. In other words, it's building on what are some of those current routines and activities that are already going on throughout their day. Additionally, we'll talk about the pieces of the Child and Family Assessment. In key principle number 6, where it states the family's priorities, needs, and interests are addressed most appropriately by a primary provider who represents and receives team and community support. So now we're going to talk a little bit about those priorities, interests, and natural resources as part of the Child and Family Assessment. Within that, there is the summary of routines and activities, and that identifies and summarizes current routines and activities of the family. What routines and activities are going well for the child and family? Where might we need some additional help? When we think of natural resources, we aren't necessarily looking at financial resources. We're trying to identify resources that currently exist in the family's everyday home and community setting. For example, parks, playgrounds, churches, and we also want to extend this to think about people as natural resources. For example, grandparents, neighbors, friends, existing playgroups. Interests are areas where the family would like more information. For example, additional information on childcare, opportunities for my child to play with other children, diagnosis information, or even perhaps talking with another parent. Priorities are routines and activities identified in the Child and Family Assessment that the family has expressed need for home and community participation and inclusion. So let's think of this as an example. Well, as we look at our diagram here, where we combine natural resources, priorities, and interest to produce a functional outcome that's determined by the family. So for example, a family has expressed interest that they want to attend church together as a family. However, right now we're unable to attend due to our son Johnny's inappropriate behaviors during service. Identifying natural resources might be contacting a local nonprofit organization that might help train the family. In addition, an intervention perhaps would be that the occupational therapist attends the first or second service with the family to assist with training and coaching the family with interventions. The functional outcome is that we're attending church together as a family. So to recap, remember discussing that the process should be dynamic and individualized earlier. Child and Family Assessment identifies what that routine currently looks like. The functional outcome describes what it will look like when it's going well for the family.
So let's talk through another example in thinking of functional outcomes. For this example, the team has identified that grocery shopping is something that has been quite a challenge for the family and something everybody's agreed to work on. So the family, prior to developing this plan, had only been able to go grocery shopping at night when both parents were home and weren't able to take Juan with them. So one parent would stay home with Juan Jr., and the other parent would go and do the weekly shopping. Through discussion, the team agrees that success will look like our outcome listed here. So when Mercedes and Juan Sr. take Juan to the grocery store, they'll be able to keep him interested enough that he will either ride in the cart or walk with them for a trip that doesn't last more than 30 minutes. So that's going to be successful for them. They're not going to try to do a 2-hour big Sunday morning shopping trip. They're going to just do a nice 30-minute in and out. So in looking at the natural resources, we're going to identify the people involved and the item we need to be successful with our intervention, the items. So the people involved are the mom, developmental special instructor, perhaps a neighbor. We're going to use a grocery cart book. And we'll discuss some possible interventions that the team could implement to make progress towards this outcome in just a few slides. But this is a good example that illustrates putting the priorities, the natural resources together to address the functional outcome.
The team lead is chosen after the outcomes are developed. The team uses the identified child and family concerns to identify a likely team lead. The team lead is not chosen until after the outcomes are developed using the information gathered during the evaluation and assessment process. Once the team lead is identified, the team also reviews how other team members will support that team lead and the family to support the child and family's achievement of the outcomes. The team lead is the primary provider. They are not, however, the only provider to the family. The family is supported by the entire team. The other members of the team are always aware of the needs of the family and support the team lead in many ways. The family and the team lead may ask other members of the team to come on a visit, known as a joint visit, to support the family and team lead when they have questions or concerns, or when the team lead does not have the specific skill or expertise required. For instance, if the speech-language pathologist is the team lead for the family, she and the family may ask the occupational therapist or physical therapist on the team to join them for a joint visit when there's a question about positioning the baby to ensure that she is breathing well when they introduce cereal at mealtimes. The team lead begins each home visit with a review of the joint plan developed during the previous visit. They explore with the family the successes, any challenges encountered with the previous plan. They may work on refining the prior week's plan, or they may already have a new plan in mind for the current visit. The team lead may observe the family may observe the team lead. They might meet in the bathroom to work on bath time or potty training. They might meet at the kitchen table to work on mealtime, or they might meet in the park to discuss how to ensure that the child can participate in outdoor activities. Every home visit ends with the development of a joint plan. This plan identifies what both the team lead and the family want to do between visits, opportunities for practice. It outlines what strategies and activities each might undertake, and it ends with an agreed upon schedule for the next visit. Rather than having a set 10 a.m. on Tuesday time slot, providers use a flexible, activity-based scheduling that allows them to see families as frequently as needed. Families may need bursts of service, and this flexible, activity-based scheduling allows providers to be more dynamic and responsive to the needs of the families. So we just talked about that flexible, activity-based burst of service. That's what we call FAB or FAB scheduling. Once the decision is made who will serve as the team lead for a particular child and family, the frequency, intensity, and duration of support provided by the team lead and any needed joint visits with the secondary service provider must be specified. I'm going to direct us again to the webinar companion. There's some excellent examples of how FAB scheduling is flexible and activity-based within the normal routines of a family's daily life. Bursts of service for a newly enrolled child and family, or perhaps a child with a severe feeding challenge. For example, they're losing weight, vomiting, and swallowing issues to address support for all people feeding the child during all meal times.